To be with you today to talk about a high-value care approach to diagnostic testing and to kick off this high-value care symposium portion of the conference. I don't have any disclosures for this particular talk. As we just heard actually from our last speaker, the things that we are technically capable of doing are quite impressive. He talked about precision medicine and molecular diagnostics and PET scans and MRIs and things that we couldn't even do not too long ago. Even when I was finishing training just over 10 years ago, we didn't have a cure for hepatitis C yet. We didn't have even direct oral anticoagulant therapy. The pace of breakthroughs, I think, are breathtaking. And yet, we are technically or theoretically able to do these things. We inconsistently are actually able to deliver that to the people who need it most. And in fact, the evidence is increasingly clear that patients receive both too much and too little health care. Oftentimes within the same country, within the same health system, oftentimes within the same patient, they're getting health care that does not make them healthier, and they're not getting things that have a strong evidence base that would make them healthier. And so this, I think, continues to grow on the evidence-based medicine movement that Dr. Guyat nicely presented earlier today. So high-value care is a framework for us to think about how do we balance that clinical benefit with the costs and the harms, with the goal of improving patient outcomes. High-value care is, can we answer the question, is it worth it? Just because something's expensive doesn't mean it's good, doesn't mean it's bad, but the question is it worth it? And the ultimate goal is to ensure that we're actually improving patient outcomes with what we're doing. In many of our countries, this is a challenging recognition and public health campaign to convince people that more is not always better. Getting more health care can actually come with lots of harms. More is not always better. And in fact, the evidence also is increasingly clear that overuse in healthcare is actually a patient safety problem, that it causes both physical and financial harms. Those financial harms accrue at every level, from the societal level, the country level, to the individual level, and in countries like the United States, it really is a major problem for individual patients who are stuck with exorbitant bills that they cannot pay. Dr. Korenstein and colleagues in JAMA Internal Medicine a few years ago helped start to conceptualize and capture all of those hidden harms and all those hidden costs. It's not just the monetary financial cost, which takes away from other global priorities, but indeed, there are physical, psychological, social, and treatment burdens, both short and long-term consequences from healthcare that does not make people healthier. The antibiotics for viral upper respiratory infections, the head CTs when there are no red flag symptoms, the back MRIs, so on and so forth. There may be differences between our countries and where the areas of underuse and overuse lie. But everywhere that they've looked at this, there are examples. I was in Costa Rica this summer and I thought, oh, surely they don't have too much overuse here. And as I spoke to the doctors, they said, actually, every outpatient with COVID is getting a CAT scan, a CT scan right now, which clearly was overuse. So there might be differences between where those areas are, but they tend to exist. Those harms are also captured in this infographic from the Commonwealth Foundation, which was put together with Choosing Wisely Canada. Once again, looking at when we provide interventions in healthcare that don't help, they cause harms individual level, provider and organization level, and within the healthcare system. And increasingly, we recognize that a lot of those harms are hidden because they open up care cascades. In other words, you order a single test, and that test shows something abnormal, which then causes you to order another test, which then causes more worry, more testing, more interventions. And too often, if that initial test or intervention was unwarranted, it doesn't actually improve to better outcomes, but indeed worse outcomes. So once again, Korenstein and colleagues captured what some of those care cascades look like. And one of my colleagues at Harvard in the United States, Ashani Ganguly, has been starting to study and actually quantify what some of those harms look like. So if you get an EKG before an operation, how many of those unnecessary EKGs lead to echoes? How many of those echoes lead to stress tests? How many of those stress tests lead to casts? And did you actually improve the health of the patient? A lot of times you end up doing interventions on the patient and they never get the surgery that they initially wanted, and you didn't actually improve their life. So what do we do about it? Well, Choosing Wisely was a campaign that started 11 years ago in the United States by the American Board of Internal Medicine there, with the goal of starting these conversations about common areas of overuse and the harms of overuse. It has since actually grown spontaneously into an international movement. So there are Choosing Wisely campaigns in many countries across the world. And as I mentioned, although some of the nuance around what drives overuse and where the areas of overuse are may be different, we all have in common that there are areas where we provide too much care. And Choosing Wisely, as I mentioned, was really meant to trigger conversations, to recognize the power of conversation in starting to talk like we are today, to discuss with each other harms of overuse, to talk about the things that we do within our own practices. Stop pointing the finger at others and saying, it's the cardiologists that stent too much, or it's the emergency room doctors that do that. Choosing Wisely was about, let's look at our own practices and identify that. And let's start to have these conversations with each other. And let's start to have these conversations with our patients and the public. So before we make a recommendation, whether that is a study or a test or a treatment, what Choosing Wisely prompts us to do is to say, what are the benefits? What are the risks? What are the alternatives? And what if I do nothing? Many of us do weigh these, but being more cognizant of doing this systematically is what Choosing Wisely is after us doing. And they've created a number of resources for use. They have these little pocket cards for patients to remind patients some of these questions they can ask their physician. And they've created handouts for both clinicians and for patients to help guide through common conditions, such as low back pain, headaches. So let's take a step back and make this into our real everyday lives. I'm a hospital medicine doctor. I work in the hospital in Austin, Texas, and actually will be carrying the admitting pager a week from today. And I may get this page that I'm called to admit a 54-year-old woman who's presenting with acute pleuritic chest pain and dyspnea. And you, like me, start running through a differential diagnosis. You think you know what this is, and you start thinking about all the different things this could be. Is it a PE? Is it pericarditis? Is it a pneumothorax? What sort of things could be presenting? And what sort of test should we get? And what a high-value care approach asks us to do is to get back to the basics, to get back to thinking about our pre-test probability before we decide whether or not we get a test. To think about, will this test actually change our management? Is there something we will do differently with the results of this test? Something I ask our trainees all the time. You know, a trainee says, let's get a chest CT. Okay, great. Will that change our management? What are we going to do differently? And what we think about is, where on this spectrum do those different diagnoses lie? So some of the diagnoses are so unlikely that we don't need to test them, we don't need to treat them, we don't need to think about them anymore. We put them in the, okay, that's the come back to if it really turns out to be none of the other things. Some of our diagnoses are so likely that we don't even have to test, we can just treat. And others, we need to get more information. And one of the ways that we need to think about this is to think about what are the consequences of both the diagnosis and the treatment I'm proposing. So we all know, of course, if you're going to give chemotherapy, you have to be as close to 100% sure as possible. So we need to do testing, usually biopsies. You need to have the information in hand before you give that treatment. But if you're going to treat, allergies, the consequences are much, much lower, and you can just go ahead and start the treatment without doing any sort of testing or more information. You don't have to be sure. So if I give you more information about our patient, her heart rate's 95, her blood pressure is 108 over 65, she's breathing 16, satting 96% on 2 liters of oxygen. She's found to have left greater than right lower extremity edema. Her complete blood count is normal. Her chemistry panel is otherwise normal except for an elevated creatinine, giving her an estimated GFR of 33. Her EKG shows some mild sinus tachycardia with a heart rate of 101, and her chest x-ray is read as clear. So now we go back and think, where do we put these different diagnoses on the spectrum? And many of you, like me, recognize that this is not a challenging clinical dilemma. But the question is, are we still at the point where we'd feel comfortable enough to treat and put somebody on anticoagulants, or do we need more testing? Will it change our management is the question. And so that's the charge from high value care, for us to think about how will these diagnostic tests advance and help move us on that spectrum to whether we're going to be comfortable testing or treating. What are those downstream harms? What are the potential care cascades that can come from me obtaining this one test? Oftentimes we think about diagnostic tests perhaps as like, could help, won't hurt. And what high value care is increasingly recognizing is in many situations, it can hurt. We have to start to recognize that. The other thing is that clinicians and patients both frequently overestimate the benefits and underestimate the harms of medical interventions. So even when we do that calculus before we order something, we also have to recognize our own bias in overestimating how much benefit people will get from a certain thing and underestimating all of those downstream harms. This comes from a JAMA Internal Medicine article from a few years ago. Couple resources, if you want to learn more, dig in more. JAMA Internal Medicine has an entire series that goes back more than a decade called Less is More, where they identify these frequent areas where less healthcare actually provides better benefit. So areas where certain interventions cause clear harms for patients. The Journal of Hospital Medicine has a Things We Do for No Reason series, one of our favorite series to look at with our trainees, with our residents, all the time when I'm on the wards, showing why did we do that thing? Why did we give that medication that has been shown to not help? Docusate, that's the name. I want to say Colace, but that's the trade name. So Docusate, the generic name, doesn't help at all. We give it to our patients all the time in the hospitals where I work. And so Things We Do for No Reason points out the evidence behind it and shows areas where we do things for no reason. So that is just a quick overview about high value care, balancing the benefits and the harms, thinking about before we order tests, what are the potential benefits? Will this change management? What are the potential downstream harms? And recognizing more and more that there are care cascades that we can start or open up if we are not careful. And so with that, I want to thank you.